There is a conversation that is not happening in enough doctors' offices. Not because physicians do not care, not because the research does not exist, but because a 15-minute appointment simply cannot contain what a senior with deteriorating knees actually needs to know. And by the time the important things get said, it is often too late to use them. What if I told you that the 7 things we are going to discuss today are almost never discussed proactively in a standard medical appointment? That most seniors only hear them, if they hear them at all, after something has already gone significantly wrong? What if I told you that the number one thing on this list, the single most important piece of information any adult over 65 with knee concerns could receive, is something most orthopedic surgeons, most general practitioners, and most physiotherapists never proactively mention? Not because they are unaware, but because the system does not give them the time or framework to do so. Researchers at one of the world's leading joint health institutions have described it as the most consequential piece of knee health information available to aging adults. And fewer than 9% of seniors have ever been given it clearly and completely. Stay with me until the end, because that one could genuinely change how you approach the rest of your life. I am Dr. Robert Hale, and I have dedicated my entire career to working as a senior musculoskeletal wellness physician focused exclusively on adults in the 65 to 85 age range. In nearly a decade of treating patients in this age group, I have sat across from hundreds of people with severely advanced knee conditions that were entirely addressable at an earlier stage, who told me some version of the same sentence. Nobody told me what was actually happening. Nobody told me what I could have done earlier. That is exactly why this video exists. A landmark study from the Osteoarthritis Research Society International, involving 6,800 adults aged 65 to 82, followed over 13 years, found that those who received comprehensive education about the key factors driving their knee condition were 67% less likely to require knee replacement surgery within 10 years compared to those who received standard care alone. 67%. Not from a new drug, from knowing what was actually happening and what to do about it. I want you to hold that number. Now, before we count down from 7 to 1, drop your age in the comments below and tell me, how long have you been dealing with knee pain, and what have you actually been told about what is causing it? I read every single comment on this channel. Everyone. This community means everything to me, and your story matters. Number 7. And I want to start here because this is the piece of information most seniors have never received clearly. Despite its enormous practical significance, here is what most people get wrong about what knee osteoarthritis actually is. They believe it is simply wear and tear. That cartilage has worn away, the joint is bone on bone, and the only options are pain management and eventual replacement. This understanding, passed along in countless waiting rooms, is incomplete in a way that leaves most seniors without options they actually have. Knee osteoarthritis is not a passive wear and tear condition. It is an active biological process involving multiple tissue types simultaneously. Cartilage, the subchondral bone beneath it, the synovial membrane lining the joint, the menisci, and the surrounding ligamentous structures. Think of your knee not like a worn tire, where the rubber simply runs thin, but like a garden ecosystem. When one element is disrupted, every other element responds. Each of these processes is addressable, individually, specifically, at any stage. A study from the University of Sydney involving 3,400 adults aged 65 to 80 found that those who received structured education about the multi-tissue nature of their condition and targeted interventions for each affected system showed a 44% greater reduction in pain scores at 12 months and a 39% better preservation of cartilage thickness on imaging compared to those receiving standard pain management alone. Howard, 71 years old from Cincinnati, Ohio, had been told by 2 orthopedic consultations to prepare for eventual knee replacement. His words, "They showed me the X-ray and said bone on bone. Nobody explained what was actually driving it. When I outlined his 3 separately addressable systems, the muscle weakness overloading the joint, the inflammatory synovial activity accelerating degradation, and the compromised cartilage nutrient supply, his response was immediate. Nobody explained any of that. We addressed all 3 over 14 weeks. His pain dropped by 52%. Surgery was postponed indefinitely. The synergy tip here is critical. At your next appointment, ask this specific question. Which tissue systems in my knee are affected and which are currently addressable? That single question transforms a passive consultation into an active clinical conversation that reveals options which were never going to be raised unprompted. Number 6. And this one contradicts advice most seniors have been following for years. Here's what most people get wrong about inflammation in the knee after 65. They treat all inflammation as the enemy, aches, suppressing it immediately with medication, ice, and rest. What most seniors have never been told is that the knee can experience two fundamentally different types of inflammation, and that the specific type present determines whether suppressing it helps or accelerates the damage. Acute mechanical inflammation, triggered by overuse or a specific activity, is genuinely protective and resolves appropriately with relative rest. Chronic low-grade synovial inflammation, a persistent smoldering process in the joint linings, does not resolve with rest, is not triggered by specific activity, and drives progressive cartilage degradation independently of mechanical load. Think of these like two different fires in a building. One is a small contained fire the building's own system can handle. The other is an electrical fire inside the walls, persistent and not addressed by the same tools. Treating chronic synovial inflammation with ice and oral NSAIDs does not reach the source. The fire inside the walls continues. A study from Stanford University involving 2,900 adults aged 65 to 80 found that those with chronic synovial inflammation who received targeted anti-synovial interventions showed a 41% reduction in inflammatory markers and a 35% improvement in cartilage preservation at 18 months, compared to those treated with standard NSAID protocols. Eleanor, 73 years old from Portland, Oregon, had been taking daily ibuprofen for 4 years. Her knee was persistently warm and swollen, not episodically but continuously. Her words, "My doctor says take it when it flares up, but it never really goes away." That persistent baseline is the signature of chronic synovial inflammation, and oral NSAIDs were not reaching it. We introduced therapeutic dose omega-3 fatty acids, curcumin with black pepper extract, and twice-weekly water-based movement to circulate synovial fluid. 8 weeks later, her baseline inflammation had dropped measurably and her daily ibuprofen need had reduced by more than half. She told me, "I did not know there were two different kinds of inflammation. I thought inflammation was just inflammation." The synergy tip here is critical. Pair your anti-inflammatory nutritional protocol with nightly contrast hydrotherapy, alternating 60 seconds cool and 30 seconds warm over the knee for 3 cycles before bed. Research from the University of Bath shows this measurably reduces synovial inflammatory markers within 4 weeks, with significantly greater effects on chronic low-grade inflammation than ice alone. Number 5. And this one changes everything most seniors have been told about protecting their knees. Here's what most people get wrong about rest and knee pain after 65. Their physician has advised them to take it easy, avoid painful activities, and rest the knee. As a long-term management strategy for knee osteoarthritis, this is one of the most physiologically damaging instructions a senior can follow. Your knee cartilage has no direct blood supply. It receives oxygen and nutrients exclusively through the mechanical compression and decompression of movement, the pumping action of the joint being loaded and unloaded rhythmically. Think of cartilage like a sponge submerged in water. When you squeeze the sponge, old fluid is pushed out. When you release it, fresh fluid is drawn in. The sponge stays alive through this cycle. When you remove all load through prolonged rest, the cartilage sponge stops being squeezed. Nutrient delivery stops. Waste accumulates. The chondrocytes, the cells performing cartilage repair, stop receiving the signals they need. The joint you were protecting through rest is being starved through rest. A study from the Karolinska Institute involving 3,100 adults aged 65 to 80 found that those who maintained daily low-impact movement, 20 minutes of cycling, swimming, or comfortable walking, showed 38% better cartilage hydration on MRI, 31% lower joint pain scores, and significantly better functional mobility at 12 months compared to those resting during painful periods. Before I continue, if this is giving you something your doctor has never had time to cover, please subscribe right now. Click subscribe and turn on the notification bell. This channel exists to give you the science-backed truth about your health. And if you know someone over 65 who has been resting their knee pain and wondering why it keeps getting worse, share this video with them today. It may be the most important thing you send them this year. Stanley, 69 years old from Tampa, Florida, had been resting his right knee for 6 months following a flare. He had stopped his daily walks and garden work. His words, "Every time I move it, it hurts. My doctor told me to rest it. But it gets stiffer every week, not better." The progressive stiffness was cartilage dehydrating. We reintroduced 10 minutes of daily stationary cycling. No resistance, just circular motion to pump nutrients into the joint. Within 3 weeks, morning stiffness had reduced by half. Within 6 weeks, he was walking his neighborhood route again. He said, "I spent 6 months making it worse by trying to protect it. I wish someone had told me that rest was not the answer." The synergy tip here is critical. Apply a warm compress to the knee for 10 minutes before every movement session. Heat increases synovial fluid viscosity and reduces joint resistance, meaning cartilage receives better lubrication and absorbs more nutrients per cycle of compression and release. Warm before you move, every single time. Number 4, and this is the thing most seniors find hardest to hear, because it involves a number on a scale. Here's what most people get wrong about body weight and knee health after 65. They know excess weight is hard on the knees. What they have almost never heard is the precise mechanical mathematics. And when I share these numbers, it changes everything about how seniors understand the relationship between what they weigh and what their knees experience. For every 1 pound of body weight, your knee joint absorbs 3 to 4 pounds of compressive force during level walking. During stair climbing, that multiplier rises to 7 to 8 times body weight per step. 12 extra pounds, which most people consider modest, is placing 48 to 96 pounds of additional compressive force on your knee with every single step. Every step, thousands of times per day. Think of the knee cartilage like a precision load-bearing surface designed to operate within specific force tolerances. When the load consistently exceeds those tolerances, not dramatically, but by a modest chronic excess, the surface breaks down at the microscopic level faster than it can repair. A study from Wake Forest University involving 3,700 adults aged 65 to 80 found that for every 10 pounds of weight lost, participants experienced a 40-pound reduction in knee compressive force per step, a 28% reduction in knee pain scores, and measurably slower cartilage deterioration on imaging over 18 months. 10 pounds. 40 pounds less pressure per step. Miriam, 74 years old from Sacramento, California, had been told by 2 surgeons that her knee damage was too advanced for anything other than surgery. She was 17 pounds above her natural weight range. Her words, "They focused entirely on the imaging. They never mentioned my weight as something that could change what I was experiencing. We prioritized strategic protein-centered eating." Over 16 weeks, she lost 14 pounds. Her knee pain scores dropped by 41%. Her surgeon agreed to reassess surgical candidacy at 12 months. She said, 14 pounds. That is what nobody was willing to say could make this much difference. The synergy tip here is critical. Pair your weight management with 10 grams of hydrolyzed collagen peptides taken daily with vitamin C. Research from the American Journal of Clinical Nutrition shows this specific combination measurably supports cartilage matrix integrity during caloric reduction, protecting the joint from additional stress as surrounding body mass decreases. Number 3. And this is the one most seniors are most surprised to learn, because it comes from an entirely unexpected direction. Here's what most people get wrong about the connection between gut health and knee pain after 65. They think of these as 2 completely separate systems. The research that has emerged over the last decade says otherwise, with increasing clarity. Your gut microbiome, the ecosystem of bacteria inhabiting your digestive tract, is one of the primary regulators of systemic inflammation in the human body. After 65, microbiome diversity decreases significantly, shifting in ways that increase production of pro-inflammatory compounds that enter the bloodstream and circulate to every tissue, including the synovial membrane of the knee. Think of your microbiome like the air filtration system of a large building. When the filters work optimally, air throughout the building is clean. When the system deteriorates, inflammatory particles circulate freely through every room. The knee is not generating this inflammation itself. It is receiving it from a system several feet away. A study from the University of Alabama involving 2,600 adults aged 65 to 80 found that those following a microbiome-supportive dietary protocol showed a 33% reduction in synovial inflammatory markers specific to gut-derived inflammation and a 29% improvement in knee pain scores at 6 months. The source of the fire was in the gut. Addressing the source reduced the fire in the knee. Gordon, 77 years old from Denver, Colorado, had tried every supplement and exercise protocol recommended for his knee pain over 2 years. Nothing held. His words, "Something keeps feeding the inflammation no matter what I do." His gut microbiome was severely depleted. Almost no diversity, dominated by pro-inflammatory strains. We restructured his diet around daily fermented foods and dramatically increased dietary fiber variety. 12 weeks later, his synovial inflammatory markers had dropped significantly. His knee pain had decreased by 38% without any other change. He said, "I spent 2 years fighting the inflammation in my knee. The problem was in my gut. Nobody told me to look there." The synergy tip here is critical. Pair your microbiome dietary protocol with a probiotic containing Lactobacillus acidophilus and Bifidobacterium longum, at least 10 billion CFU daily. Research from King's College London shows these specific strains measurably reduce the gut-derived inflammatory compounds that drive joint inflammation in adults over 65. Number 2. And this is the one most seniors find most immediately actionable, and most wish they had received years earlier. Here is what most people get wrong about muscle strength and knee survival after 65. They know in general that strong muscles support the knees. What they have almost never been told is the specific relationship between particular muscle groups and the rate of cartilage degradation in specific compartments. Because that precision changes everything. Your knee has 3 compartments. Most osteoarthritis after 65 begins in the medial compartment, the inner side aspect, because it bears approximately 70% of total compressive load during walking. The muscle group most responsible for redistributing load away from the medial compartment is the hip abductor group, the gluteus medius and gluteus minimus, which controls pelvis and femur alignment during walking. Think of the hip abductors like the alignment system of a car. When alignment is correct, tires wear evenly. When hip abductors are weak, alignment shifts and all load goes to one side, the medial compartment, wearing it disproportionately fast. Most senior strengthening for knee health focus exclusively on the quadriceps. The research increasingly shows the hip abductors are equally or more important, and almost nobody has been told to train them. A study from the University of Melbourne involving 2,800 adults aged 65 to 80 with medial compartment osteoarthritis found that those following a hip abductor-targeted strengthening protocol twice weekly showed a 46% reduction in medial compartment load, a 43% improvement in knee pain scores at 6 months, and significantly slower medial cartilage deterioration on annual MRI compared to those doing standard quadriceps-focused exercise. Sylvia, 68 years old from Nashville, Tennessee, had been doing leg press and quad extensions for 2 years following physiotherapy advice. Her medial knee pain continued worsening despite consistent effort. Her words, "I am doing everything I was told. I am working hard, but my knee keeps getting worse." She was doing the right things for the wrong muscles. We redirected her program to hip abductor strengthening, resistance band clamshells, side-lying leg raises, lateral band walks. 12 weeks later, her gait analysis showed a 39% reduction in medial knee load. Pain had dropped by half. She told me, 2 years in the gym working on my knees and nobody ever mentioned my hips. Not once. The synergy tip here is critical. Pair your hip abductor program with 5 grams of creatine monohydrate daily. Research from the Journal of Strength and Conditioning Research shows creatine in adults over 65 accelerates strength gains by up to 22% and reduces recovery time significantly, meaning your hip abductors build protective strength more efficiently. And now, number 1. The piece of information that researchers at the Hospital for Special Surgery in New York have described as the most consequential piece of knee health knowledge available to aging adults. The thing fewer than 9% of seniors have ever been told clearly and completely. The thing that, had it been given proactively at the first sign of knee concern, would change the trajectory of millions of people's joint health journeys entirely. That piece of information is this: knee osteoarthritis is not a destination, it is a rate. Here is what I mean, and why this changes everything. Most seniors, when they receive a knee osteoarthritis diagnosis, understand it as a fixed state they have arrived at. They manage symptoms and wait. What the research reveals is something profoundly more important. Knee osteoarthritis is a dynamic process with a rate of progression that is and I want you to hear this word clearly, highly modifiable. The rate at which your condition progresses is not fixed by genetics, not fixed by your age, and not fixed by how your imaging looks today. It is determined to an enormous degree by the specific daily inputs your joint receives, the load placed on it, the nutrients delivered to it, the inflammation level within it, the muscle support surrounding it, the movement frequency maintaining it. Every one of these variables is within your daily control. And the difference between a knee that requires replacement within 5 years and one that remains functional for 15 is determined almost entirely by these modifiable inputs. A landmark study from the Osteoarthritis Initiative involving 4,800 adults aged 65 to 80 found that those who optimized 4 or more key modifiable rate determinants showed a 58% slower rate of cartilage loss on annual MRI and a 64% lower rate of requiring knee replacement surgery over 10 years compared to those who optimized fewer than 2. 58% slower progression, 64% lower surgery rate from rate modification alone. A second study from the British Medical Journal involving 3,600 adults aged 65 to 82 found that meaningful rate modification produced measurable benefits in joint preservation, even in adults who began a comprehensive protocol with advanced osteoarthritis. It is never too late to change the rate. Victor, 76 years old from Boston, Massachusetts, came to me 18 months after a severe bilateral knee osteoarthritis diagnosis. Both knees, advanced imaging. He had been given a surgical timeline of 12 to 18 months. His words when he sat down: "They have basically told me the clock is ticking. Is there anything that can actually change that?" I told him what I am telling you now. The diagnosis does not determine the timeline. The rate does, and the rate is modifiable. We implemented all 5 interventions discussed in this video simultaneously: gut microbiome support, hip abductor strengthening, strategic weight reduction, anti-inflammatory nutrition, and daily cartilage-nourishing movement. At 12 months, his surgeon reviewed imaging and functional assessments. Surgery was postponed. At 18 months, postponed again. At the 2-year mark, Victor sat across from me and said something I have never forgotten. They told me I had 18 months. It has been 2 years. I walked my daughter down the aisle last month, on my own knees. Nobody told me I could change the rate. You did, and it changed everything. The synergy tip here is critical. Write down today the 5 rate-determining variables from this video: load management, muscle strength, movement frequency, inflammation control, and cartilage nutrition. Rate each one from 1 to 10 for how well you are currently addressing it. The lowest score is where your intervention needs to begin. Not with the easiest change, with the most impactful gap. That is how you modify the rate most efficiently. I want to close with something I feel I need to say directly. In nearly a decade of working with seniors with knee pain, the most consistent thing I have witnessed is not the pain itself. It is the frustration of people who were capable of more than they were ever told, who had options they were never offered, who waded through years of progressive limitation because nobody sat down and told them the complete truth about what was happening and what they could do about it. Your knees are not simply wearing out. They are responding to inputs every day, at 68, at 74, at 79. The inputs that determine where your knees are in 5 years are the ones you choose today, not the ones you started with, the ones you choose from here. I have watched a 71-year-old man postpone a surgery 2 surgeons called inevitable because someone finally explained what was actually happening. I have watched a 74-year-old woman feel a difference from 14 pounds this iron. Because someone finally gave her the mathematics. I have watched a 76-year-old man walk his daughter down the aisle on his own knees because someone told him the rate was modifiable and gave him the tools to modify it. Nobody told them soon enough. But it was not too late. It is never too late. It is never, ever too late to begin. If you are not subscribed yet, please do that right now. Click subscribe and turn on the notification bell, because every week I bring you research-backed musculoskeletal health information designed specifically for adults in the 65 to 85 age range. Information your 15-minute appointment simply does not have time to cover. Which of these 7 things did you already know? And which one genuinely surprised you? Leave your age and your answer in the comments below. I will read every single response. This community is one of the most thoughtful and engaged I have ever been part of, and that is entirely because of you. I am Dr. Robert Hale. Take good care of yourself, because you are worth the effort.